Good evening, everyone. I think we are coming to the last session of the program. It's nice to see such a large crowd staying till the last session. And we will start with this session. This is something like a rapid fire session. It's only 10 minutes. Many of you will be wondering why we gave only 10 minutes. I think some of the speakers were not happy with 10 minutes. But it's only the crisp messages to be given. It's not a full lecture, it's just a rapid fire session.
I always have one comment in any conference. We know that whenever we talk about management of diabetes, we talk about lifestyle, which includes medical nutrition therapy. But unfortunately, in all the conferences, I don't know why, this part of the lecture is always at the end of the session. So I have been telling the organizers to, I think you talk about lifestyle, including medical nutrition, then only talk about oral agents and injection. But for some reason, it is always at the end of the session.
There is a reason for
yes,
there is a reason for that.
Yeah.
It will hold the people till the end. That's the reason. That is number one.
Session, you will get a lot of questions also on this session. It's an interesting session without time limit, so we'll have some time limit. Without time limit for questions. The speakers are going to be very sharp. They are going to finish in 10 minutes. So I call upon the first speaker, that is Dr. Ashwin Karuppan. He is going to talk to us on a very, very interesting topic, that is intermittent fasting, boon or bane. I think it's in the social media everywhere about intermittent fasting. And in 10 minutes, he is going to show what is intermittent fasting, and so that you can later take up questions with them.
A very good afternoon or late evening, should I say, to one and all present here. It's a great honor and pleasure to be here today, especially among the professors and professors of professors. It's a really great honor, especially Anand Moses sir, GVK sir, Mahadevan sir. I'm sure that in future we will have halls named in your name for all this, and it's not very far. So intermittent fasting, as sir said rightly, it's going to be day in, day out. Any youngsters today, they talk about intermittent fasting. So what is intermittent fasting and how is it done? And with the obesity, more and more going towards the obesity and diabetes, what we talk about, the ICMR study Diabetes says that nearly around 28.6% of these patients, the prevalence of obesity is there in general population, and around 39% have abdominal obesities. I don't have to tell that right now if we count the number of people in this hall. So coming to the intermittent fasting, we have various kinds of intermittent fasting, which is alternate days fasting. And on the day of fast, we restrict ourselves to 500 kilocalories. And then on the feast days, we take whatever we want. And at the same time, we have time-based and weekly also, that is 5:2. And then you have the time-based fasting, which is most commonly followed. And this is not the first thing that intermittent fasting, it is not only from our new modern science, but also if you see in almost all the religions, they follow intermittent fasting for one or the other, starting from Christians' Lent days, starting from Navaratri, which is going to come up, and so many other follow-ups. So when it comes to time-restricted feeding, it's always like 16:8, and then comes to the 24 and 5:2, and then 36 hours and 24 hours fasting, where in all this, the simple concept is restriction of calories and extending the prolonged fasting periods. So how does intermittent fasting work? It first decreases the fat mass without compromising on lean mass, decreases resting heart rate oxidative stress, it decreases the TGL and the LDL levels, decreases CVD risk, decreases fasting blood glucose insulin levels, increases the insulin sensitivity, increases adenopectin, which also helps in reduction of gluconeogenesis, increase glycolysis, and probably more of fatty acid oxidation. And also it protects us from the oxidative stress of various TNF alpha. When you come to benefits of intermittent fasting, various studies have clearly stated that it boosts memories, especially in animals, verbal memories in human beings, It improves the blood pressure, resting heart rate, and it also increases the endurance in running in these patients, especially in men who fasted for 16 hours. Fat loss while maintaining the muscle mass was achieved. And in type 2 diabetes patient in obesity, there is a loss of body weight along with decreased fasting glucose, insulin levels, leptin levels, and increase of adiponectin. When it comes to intermittent fasting and type 2 diabetes, it always goes without saying that we have a lot of insulin resistant diabetes among ourselves. So most of our populations are insulin resistant diabetes, and with caloric value restriction, we have found that there is increased insulin sensitivity, decreased insulin levels, thereby improved fasting and postprandial. And it also helps us less propensity to gain weight. Now that we are talking more about the intermittent fasting and people with diabetes, and what class of drugs actually we need to give in these patients. So if you can see, most of these drugs, except for sulfonylureas, are much safer when we encourage intermittent fasting in most of these patients. And then insulin is always a high risk, whether it is an insulin pump or a long-acting insulin, basal insulin, especially the newer generations which are also at risk but at moderate risk compare. So we always need to advocate that to reduce the dose or skip the doses on that particular day, which might lead to great fluctuations. So who needs to avoid intermittent fasting? Basically children less than 18 years old, pregnant women, type 1 diabetes where the risk of decay is high. At the same time, people who have solid organ transplantation, any kind of eating disorders, do not suggest any intermittent fasting. So what are the risks of intermittent fasting? The first one is hypoglycemia, which is very common, especially when you are in OHAs or you are on insulin, anti-diabetic drugs. Then you come to the protein, vitamin, and mineral malnutrition, especially vitamin B12, which we were just discussing just before the start of the session. And then we also see multiple other vitamins, which is C, D, E, and most of the vitamin deficiencies are there. What are the other commonest side effects? You have irritability, fatigue, headache, decreased alcohol tolerance. Dehydration is one of the most commonest, thereby leading to constipation, because if you drink less water, people get constipated very easily, especially when they are on more of supplements and less of fiber intake. What are the clinical trials? The clinical trials, just the 4 main trials which I went through the internet and saw what are the basic 4 trials which talk more about it and has the maximum citations. If you can see the intermittent fasting and health outcomes, an umbrella review of systemic reviews of meta-analysis of randomized controlled trial, which includes the PubMed, Embase, Web of Sciences, and Cochrane database, and they have found out that people who have undergone intermittent fasting for 1 to 2 months has reduced fasting insulin, especially with overweight and obese people. And participants with obesity, lower fasting blood glucose, they also found that there was a decreased fat mass, LDL-C cholesterol, TGLT-C, and then fasting, and also there is an increase in high density cholesterols. Coming to the next, they also studied one of the study where there was a 4 hours and a 6 hours time restricted feeding period. This also found to be that there was no difference, but the energy intake was reduced by 550 kilocalories per day. And there also we can see that there was a mild reduction in body weight, and there was a decrease in insulin resistant and also body weight loss. Similarly, this study says that intermittent fasting, even if you don't lose weight, it says that it improves insulin sensitivity, blood pressure, and decreases oxidative stress, even if patients who are pre-diabetic have not lost weight, since even then there seems to be a kind of benefit for all these patients. And the last study which I was talking about, so 8 hours time restricted fasting, which was come out in March 18, 2024. It was a huge thing for all of us to know that 8 hours time restricted fasting was linked to 91% of higher risk of mortality in most of cardiovascular deaths, where 20,000 patients were retrospectively analyzed, and then they found out that it was 91% higher risk of cardiovascular death, but nobody knows why. And probably they have made a comment in that saying that it needs further study to understand why this is happening. So this is one negative study which is very important, which came out from the AHA. So what is stopping us from prescribing all of this, if this is so good? The first one is, it is not effective for everybody. There are families who eat twice a day. We know that. And in traditional Brahmin families, yes, we do eat twice a day. And similarly, we see a lot of other people who eat once a day, but we cannot live like a monk. We human beings are the only mammals we eat even if we don't feel hungry. So that's how it is. So we cannot live, we are compulsory snackers, we cannot live without eating, so it becomes a little difficult for us to practice this. Possibility of muscle wasting, frequent hypoglycemic episode, and nutrition consumption. And we do not pay enough attention for lifestyle diseases, which, as Sir said, that I'm a strong believer of lifestyle diseases. I make sure every one of my patients sees the nutrition before they leave my OPD. And I think that is for every visit, I make sure that they will see the nutrition and then leave. So that is how it comes. And I want to close this session by saying this. உணவை மருந்தை போல் சாப்பிட வேண்டும், இல்லாட்டி மருந்தையே உணவா சாப்பிட வேண்டும். So this is how it is. I think my Tamil is wrong, so உணவே மருந்தாகிவிடும். So this is how the session goes. And today is the World Heart Day. So my message is prioritizing heart health, stay active, eat well, and managing stress. Thank you one and all for your patient listening.
Thank you, Dr. Ashwin. A wonderful talk, but also you opened a Pandora box. We'll have a lot of discussion, lot of controversy, lot of discussion, and other nutritionists are there. They are going to get it. Okay.
Thank you.
We'll have it a panel discussion at the end.
Sure, sir.
Okay.
Thank you.
Vasugi, yeah. We go to the next part of this program today, choosing the right oil, another very, very important area. I think almost every day in your clinical practice, you will be asked this question, which oil to use, which one not to use, how much to use. Because our cooking is always deep frying. Without frying, there is no food in our population. So this one question is always will be there from the patient. To tell us about it, we have Dr. R. Vasugi.
Good afternoon, one and all. Thank you, chairpersons. I thank the organizing committee for this wonderful opportunity. My topic is choosing the right oil. Very important topic, sir. 10 minutes is very less. So I'll try to finish within time. So why do we need fats? We all know we need fats as a macronutrient. Why? Because fats provide us energy. Fats are part of cell membranes and neurons, myelin sheath. We need essential fatty acids, and fat-soluble vitamins are absorbed with the help of fat. All these things we know. Then why do we need oils in the diet? Oils are the medium through which we consume dietary fat. Dietary fat is consumed mainly through oils. And what does oil do? They improve the taste, texture, and consistency of food. Can you all imagine crispy dosas without oil? Without oil in the diet, it is very difficult to have our food. So before going into the topic proper, let us know about the fat basics. All fats give us same amount of energy, but are all fats equal or all fats same? No. So there are 4 types of fats we know: saturated fat, MUFA, PUFA, and trans fat. Saturated fats, no double bonds, and the unhealthy fats, we all know that. MUFA, monounsaturated fatty acids with a single double bond, and they are healthy fats seen in several oils. PUFA, 2 or more double bonds. Again, they are healthy fats seen in few oils and walnuts. What about trans fat? Why trans fat is very unhealthy, and what is the importance of trans fat? So trans fats are also unsaturated fat which are existing in trans configuration. So in the fatty acids, when you have double bonds, they will either remain as cis isomers or as trans isomers. So trans fat usually are found very minimally naturally in dairy products, beef and lamb. However, we are getting transferred by industrial production from the vegetable oils and by constant heat treatment of oils. And as we all know, trans fat is very, very unhealthy, leading to coronary vascular diseases. So how to choose the right cooking oil? We have 6 thumb rules. One is, please, we should know the fatty acid content of each and every oil we are going to use in the diet. Know the smoke point of the oil. Choice of the oil depends upon the cooking method, the Q sign, and the method of production, and also mixing of oils. So what are the types of fats in the oil? So I've given the list. There are a lot of oils in the market, global market. So these are some 10 samples which I've taken, which are available widely in the Indian market. You can see that coconut oil and palm oil are rich in saturated fat, while vegetable oil, sunflower, safflower, and soya bean oils are rich in PUFA content. And we have this rice bran, sesame, mustard, olive. Olive oil is the richest MUFA content. So all these are rich in MUFA. So first we should know the fatty acid content of the oil we are choosing. Next is, what is this? Smoke point. So what is smoke point? It is the temperature at which the glistening nature of the oil disappears and the oil starts burning and smoking instead, imparting an accurate burnt flavor to the foods we are using to cook. So usually when women start cooking, mother and the mother-in-law will stand nearby and say, எண்ணெயை சூடு பண்ணு ஆனால் கொதிக்க வைக்காதன்னு சொல்லுவாங்க. I don't know how many of you know this term. So this is the similar smoke point. The oil has to burn, but it should not burn so well. You have to simmer that time. So why? Because for shallow frying, the temperature required is 250 degrees Fahrenheit, and both for deep frying and for baking, the temperature is as high as 350 degrees Fahrenheit. And so for deep frying, we should use oils which can withstand this temperature and which have a high smoke point. So these are some of the oils. And then cooking methods, right? So as I told you, for deep frying, use oils with high smoke point. For baking, we should use neutral oils. Usually vegetable oils are neutral oils in that they don't have flavor on their own or odor on their own. So they are very useful for baking. If you see biscuits, you will see that vegetable oil, that ingredient content will be there. So for baking, we use vegetable oils. For sorting, vadakarthukku, we will have sunflower, safflower, and peanut oil. For tempering, thalikarthukku, we use these oils, ghee, coconut oil, sunflower, and sesame. And for salads, we can use this olive oil and coconut oil. And for dosas and rotis, we all know we can use refined sesame and ghee. And depends upon the cuisine also. Globally, there are various cuisine types. Indians also, we are no less. We have different Indian cuisines. Can you imagine vattakorambu or puliyodare without nallanai? Nallanai is specifically for vattakorambu and puliyodare. You have for all Punjabi dishes ghee, avial. For avial, you should have finally thalijify with coconut oil. And for all poddies, we use sesame oil. For pickles, North India, they use mustard oil. In South India, we use sesame oil and groundnut. For Bengali dal tadka, we use mustard oil. And for Mediterranean dishes, we use olive oil. So the type of oil which is chosen also depends upon the cuisine and also depends upon the food which is being cooked. So method of production. So we have different 2 types, cold-pressed oil and heat-pressed oils, which are actually refined oils. So what are cold-pressed oils? The Chekka NN, we have been a very recent, Chekka NN is very popular in the market. This is cold-pressed oil in which the oil is obtained from the seeds by pressurizing, which is mechanical pressure, without being treated with heat or chemicals. So the most important things, they are high in nutrients, antioxidants, they are rich natural flavor and aroma, and support immune system, and they are low in cholesterol. So we have advantages of cold-pressed oils. But what are the disadvantages? They are very, very expensive. They have shorter shelf life. And these are low smoke points. In the Chekka and we cannot use for deep frying. So because they have low smoke points, so we can use it for a seasoning or sorting like that. And they might be adulterated with mineral oils because we are not purifying or refining them. So see, these are some of the examples of refined oils. Most of the vegetable oils are refined oils. And unrefined oils, we have this coconut oil, avocado, and olive. These are virgin oils. And so what is a dietary fat recommendation? So most of the guidelines, including the AHA, WHO, AAC, they are asking us to take 25 to 30% of fat, in which 7%, less than 7% must be saturated fat, and trans fat is better to avoid or should be less than 1%. So how much oil is allowed per day? This is recent NIN ICMR 2024 guidelines. The amount of oil consumed should be based on the physical activity, calorie requirement, and the BMI. So not more than 20 to 50 grams per person per day. And for sedentary lifestyle, we're all sedentary lifestyle, 20 to 30 grams, which approximately equals to 4 to 6 teaspoons per day, per person per day. So no more than 30 grams of cooking oil is needed per person per day for a person on 2000 kilocalorie diet from NIN 2024 guidelines. And omega-6 fatty acids, 6.6 grams per person per day, or approximately 1 teaspoon. And omega-3 fatty acids, 2.2 grams per day, approximately half a teaspoon. Ghee and butter limited to 1 or 2 teaspoons per day, or avoid if possible. So what is blending of oils? We can blend 2 oils in a fixed proportion, which will offer a balance of fatty acids and antioxidants. And this approach is used to enhance the oxidative and thermal stability of oils. Example, rice bran and safflower can be mixed, and rice bran and sunflower oils can also be mixed, available widely in the market. So choosing an oil based on the SFA, saturated fat, MUFA and PUFA content, WHO recommends a ratio of 1:1.5:1. AHA recommends 1:1.3:1. Indian Dietetic Association 2017 recommends saturated fat less than 7%, MUFA 10 to 15%, PUFA 5 to 10%, omega-6 5 to 8%, and omega-3 1 to 2%. So what does this mean? You should have a mixture of oil which contains high PUFA and high MUFA. So that is what? It can be a groundnut rice bean sesame with mustard or soya bean, and these. So 2 more slides, sir. And what is the best oil for frying? It should have high smoke point, neutral flavor, stable at high temperature, should not be oxidized, and it should be economical. There is no ideal oil for frying. And what about reheating of oils? Common practice in households and commercial preparations, oxidizes PUFA. I told you this trans fat comes from unsaturated fatty acids. So PUFA leading to generation of toxic compounds, production of trans fat, increases risk of atherosclerosis and malignancy. Oil once used for frying should be filtered and can be used for curry preparation, so tempering or sorting, not used for frying again. So I spoke like a dietitian, I'm a clinician basically. So clinical tips, how to translate it to the patients. Avoid deep fried foods, avoid pastries, limit ghee intake, avoid vanaspati, do not reheat oil, restrict to recommended oil intake of 30 grams per day, approximately 4 to 6 teaspoons. Oil is a necessary evil, and let us use it judicially. Thank you.
Vanga, Dr. Raja. No, he is going to speak about another talk of the town topic, that the controversy that has been created with artificial sweetness. And I think he's also going to open a Pandora box for more discussion after his talk during the panel discussion. The WHO recommendation recently and the controversy behind that.
Good afternoon to all. First of all, I would thank my mentor, Professor N. Rajendran sir, Dr. A. Shanmugam sir, who gave me this opportunity. Today I am going to talk regarding benefits and risks of artificial sweetness. Agenda of my talk is some basic introduction about artificial sweeteners, its risks and impacts in our day-to-day life, its impact on weight, its impacts in diabetes, how they affect our health, what are its benefits, and what guidelines says, and finally conclusion. Artificial sweeteners, sugar alcohols, and plant-based novel sweeteners all belong to group of non-nutritive sweeteners. They are high-intensity sweeteners that typically non-caloric or low in calories. The following molecules are belong to artificial sweeteners, and the aspartame is the most commonly used one. It is 180 times sweeter than sugar. The next one is sucralose. It's 600 times sweeter than sugar. Others are saccharin, azosulfame, potassium, advantime, neotime, allitime. So advantime is 20,000 times sweeter than sugar. Regarding sugar alcohol is commonly used in sugar-free candies, chewing gums, and soft drinks, and throat lozenges. And plant-based novel sweeteners, allulose is derived from various fruits, and monk fruits is mainly cultivated in China. It is also cultivated in some part of India in Himachal Pradesh. And stevia is, in Tamil it's called sarkari tulasi or seeni tulasi. And dextrose also from the various fruits. Artificial sweeteners are used in various food products. It's commonly used is in tabletops, what we are adding in our coffee or tea. It's also present in sugar-free biscuits, cookies, yogurt, and frozen sweets, salad dressings, and alcoholic beverages. And in pharmacological products is cosmetics, in mouth freshener, toothpaste, children's chewable vitamins, and cough syrup all contain artificial sweeteners. More than 6,000 products are using artificial sweeteners. Most of consumers are unaware about the presence of these sweeteners in their daily usage products. Although artificial sweeteners are low in calorie or giving no calorie, the weight loss and reduction in BMIs last only for short term, that is less than 3 months. There is a lack of consistent association between consumption of artificial sweetness and weight loss. WHO recommend against the use of artificial sweetness for weight loss or reduction of chronic disease risk. Artificial sweeteners increase the risk of diabetes when consumed in a higher amount in the following mechanism. Artificial and non-nutritive sweeteners acting on the gut, changing the gut microbiota, thereby change the fatty chain metabolites, thereby increase insulin resistance. In the pancreas, it increases the sweet taste receptor initiation and leads to hyperinsulinemic response to glucose response. And the brain, it's blend the cephalic response, thereby increase the calorie intake and weight gain. Increased adiposity, increased insulin resistance, and hyperinsulin response, all this leads to increased risk of diabetes. Artificial sweeteners in higher quantity were associated with higher risk of type 2 DM. There is a positive association observed between intake of total artificial sweeteners, aspartame, azosulfame, potassium, and sucralose. Regarding glycemic control, the results are varying. Some shows benefits, some shows harmful effects. The possible mechanisms how artificial sweeteners affect our health is, they regulate the E. coli and Enterococcus faecalis in the gut. They impact the heart hormones and appetite signals, the energy compensation, and there is a change in taste preference and reward perceptions, alteration in the gut-brain neuropeptide signaling. All this leads to change. Higher intake of artificially sweetened beverage like Diet Coke was associated with increased risk of stroke and coronary heart disease and all-cause mortality. Because non-nutritive sweeteners associated with increased cardiovascular risk factors, thereby they increase the risk of CVD. Regarding cancer risk, previously that saccharin was told to be causing cancer risk, but recent study shows that there is no clear evidence for association between use of saccharin and bladder cancer incidence in humans. The Nutrinet Senate cohort study shows higher intake of aspartame slightly increase the cancer risk for breast cancer and obesity-related cancers. Some artificial sweeteners might increase obesity, potentially having an indirect effect on cancer, although the findings are mixed. Till date, there is no high-quality evidence that any of the available artificial sweeteners increase risk of cancers in humans. In special population in pregnancy, although there is no increased risk of congenital anomalies, there is increase in infant BMI, childhood obesity, there is a small increase in preterm birth, there is altered childhood preference to sweet taste. Consumption of small amount of artificial sweeteners during pregnancy is acceptable. It's not advisable, it's acceptable. Regarding children, artificial sweeteners should not be a significant part of children's dietary intake. American Heart Association advises against the prolonged consumption of low-calorie sweetened beverage in children. Among non-nutritive sweeteners could be replaced high-calorie sugar-sweetened foods among children and adolescents who are obese and overweight for short period of time only, not for long time. Artificial sweeteners should be avoided in the persons with the following problem. Persons with bowel disorder like irritable bowel syndrome, inflammatory bowel disease, because a changing gut microbiota has to be with celiac disease, they should avoid artificial sweeteners. Patient who are undergoing bariatric surgery, before bariatric surgery, suppose they are taking the expected results won't be there because it changes the gut hormones. After bariatric surgery, due because of floating sensor and distance, and also to be avoided pre-bariatric and post-bariatric surgery period. In persons with migraine, depression, seizure disorders, this drugs has to be avoided. Aspartame has to be avoided in persons having phenylketonuria. Regarding benefits, the weight loss and reduction in BMI last only for short term 3 months, because artificial sweeteners present in chewing gums and candies decrease the colonization of Streptococcus mutants that cause the dental caries, prevent the dental caries, but the artificial sweetener present in carbonated drinks having acid in nature, so they are causing enamel damage, so this has to be avoided. Regarding metabolic dysfunction associated liver disease, some studies shows intrahepatic reduction in fat content, but few studies shows there is no correlation. Large studies are needed. What guideline says? ADA, people with pre-diabetes and diabetes, what is recommended over nutritive and non-nutritive sweetened beverages? Non-nutritive sweeteners as a replacement for sugar sweetened products in moderation is acceptable if it reduces overall calorie and carbohydrate intake. That is more important. Suppose we are able to reduce overall calorie and carbohydrate intake, we can use it in moderation. And finally, conclusions. Artificially sweetened beverage may increase the risk of type 2 diabetes, obesity, depression, and CVD and all-cause mortality. Sugar-free does not mean carbohydrate-free. Most of biscuits or cakes commercially available is meant as a sugar-free, but it contains a lot of carbohydrates. We have to be careful. Using artificial sweeteners not make an unhealthy choice healthy, rather it makes choice less unhealthy. May be used for a short time as a transition from sugar-rich food to healthy food. Safest drink in the world is water. Best sweets in the world are fruits. Thank you.
Thank you, Dr. Raja. That was very intense and very elaborative. We expect a lot of discussion at the end of the session. A topic which had a lot of yes and no in the last several decades. Still not settled, in my opinion. Because even 3 months back, there was an article from, I think it is from UK, which has predicted increased cardiovascular morbidity and mortality with artificial sweeteners. So still it's a controversial area. You did a very good job. Thank you very much. Now we go to the next topic. Another, it's a question in fact to Dr. Meenakshi Bajaj. Is it really beneficial? Millets, nuts and fruits. Dr. Meenakshi.
At the outset, I'm truly grateful. My gratitude to my mentors, Professor Madhavan, Professor Anand Moses sir, Professor Rajendran sir, and Vijay Kumar sir. And if I missed anybody on and off the dais, the entire diabetology stalwarts, I'm truly grateful. So the topic given to me for the next 10 minutes is, believe me, very, very difficult. I'll try my best. So when it comes to millets, fruits or nuts, they all come under the vegetarian. It's not rocket science which I'm talking. They are all plant-based diets. And we have enough and more evidence to tell us that plant-based diets do good not only to gut dysbiosis, also to mortality with any cause, and also cardiovascular health. And recently I read some data with reference to uremic toxins. So when we talk of plant-based diets, they also have an important role in excreting the uremic toxins and reducing the production of uremic toxins. So this is a recent publication in 2018, American Journal of Clinical Nutrition, which tells us that mortality is as high as 21% when you consume animal-based fats in comparison to plant-based fats. And specifically with reference to heart disease, if you replace the unhealthy saturated fat, refined carbs or trans fats with plant-based MUFA, you find that heart disease risk is much lower. This was done in a population of 90,000 subjects over 22 years. So next comes nuts. Now, when we think of nuts, actually the first macronutrient which comes to our mind is fat. It could be a mix of fats. It could be MUFA, PUFA, SFA, any of it. Apart from that, we have the protein, we have the zinc. These are certain important components of nuts. And when we talk of nuts, as I mentioned to you, when we talk of protein, there is a bidirectional relationship with reference to diabetes and sarcopenia. So protein helps in muscle protein synthesis. It's insulinotropic. Apart from that, it helps to build up immunity. And most importantly, it also acts to satiety. So nuts don't come only with protein. They come with the fat, they come with magnesium, they come with a lot of zinc, so they have an important role even with reference to immunity. And when we talk of nuts, if I say one exchange of nuts, 85 calories, which means about 12 numbers of almonds, 6 numbers of cashew nuts, 5 numbers of walnuts, 20 numbers of groundnuts, and 24 numbers of pistachios. So we have enough and more data to tell us from Dr. Anjana ma'am, Dr. Mohan, Dr. Anup Mishra et al., Dr. Madan et al. So many papers. We have more publications with reference to almonds than any other nuts, but with reference to 20 grams of MUFA being consumed over a period of time, they found that they could prevent 30% of new onset diabetes by Dr. Anjana et al. In 2015. Then came another publication by Dr. Mohan, which was on consumption of 30 grams of MUFA coming from cashew nuts, where they found there was an increase in HDL cholesterol and decrease in blood pressure. Apart from that, there was yet another paper on almonds by Seema Gulati et al., where they did find that there was an improvement in the lipid profile as well as in the HbA1c. As I made a mention to you, there are more and more papers on almonds which do talk to us and tell us that it could be an excellent way of, preventing pre-diabetes. When you consume a handful of nuts just prior to your meal, it reduces your postprandial glycemic response. But remember, a handful of nuts can give us 85 calories. So what are we supposed to do? Replace one idli or one dosa or one chapati or half cup of cooked rice with a handful of nuts, and keep in mind that you're calculating the calories. And when you choose on nuts, the best nut would be the almond when it comes to glycemic control, because it's zero carb count. And when it comes to CVD or omega-3 fatty acids, one thinks of walnuts, and remember, they need to be soaked overnight if you want to get the best benefit out of it, because the bioavailability of nutrients like zinc, copper is very, very good when it is soaked overnight. And almonds, the skin has to be removed so that the anti-nutritional factors are deactivated. Obviously, you cannot do it for walnuts and other nuts. And cashew nuts, remember, cashew nuts and groundnuts are equal evil in number in terms of saturated fat. So what does the ICMR tell us? Tells us you can include nuts, they should be unsalted. If you are going to consume the salted nuts like almonds or cashews, they are going to increase the AGE, which is again not going to do good to oxidative stress. So almonds, walnuts, peanuts, hazelnuts, pistachios, omega-3 rich oil seeds such as chia seeds and flax seeds are the prescription from ICMR. Now coming up to the next topic, that is fruits. If I talk of fruits, one exchange of fruits will be about 40 calories, which is about 8 grams of carbohydrate, 1 gram of fiber on an approximate. If I say 240 grams of watermelon is equal to 170 grams of papaya, which is equal to 125 grams of guava, which is again equal to about 64 grams of apple or 38 grams of banana. So any one of these equivalent is one fruit exchange, which would mean 40 calories and 8 grams of carbohydrate. There is a big no in so many minds of endocrinologists and diabetologists, why fruits? The reason being, they are not only a source of vitamins, carotenoids, organic acids, phytosterols, polyphenols, and a lot of bioactive components which help to reduce the oxidative stress. And we have the Academy of Nutrition and Dietetics 2023 also recommending that even if a person is PWD, you can consume fruits. But the beauty of fruits is you should take it. Usually I tell my patients when the fasting blood sugar is 100 rupees note plus or minus 20, postprandial is 150 rupees note plus or minus 20, that is the ideal time to take a fruit in between your meal, never along with the meal, never in the form of a juice or a Tetra Pak juice, never tender coconut water, never sugarcane juice unless it's a sick day diet where there is hyperemesis gravidum or the patient is a type 1 and having sick day diet. And also remember that all the My plates, whether it's a Jocelyn My plate, ADA plate, any plate, it always has a fruit along with the plate. We are already carbarians. Malai nariya sadam, mutta nariya sadam. Add on to that, you add a fruit to the My plate, it's going to worsen your postprandial glycemic response. So it's always in between the meal. Never have a unhealing wound or an ulcer or a planned elective surgery when you are going to think of consuming fruits. And when it comes to fruits, we have the cherries, oranges, pears, papaya, apple, and one interesting fruit which I identified while I was preparing this slide was ice apple or the nung. Nung is also glycemic friendly. So we don't only look at the glycemic index, we also look at the glycemic load. So there are certain fruits like watermelon, which has more than 70 glycemic index, but you see the glycemic load is much lower than 5. So we have the 5, less than 5 is an excellent choice. And I would say conveniently, if you use the citrus fruits, guava, all these are low in GI, except for the fact that when it comes to sapota palam, when it comes to dates, when it comes to bananas and mangoes. See, though mangoes we read GI is medium, GL is low, but believe me, the riper the mango, the higher is the postprandial glycemic response, and is the patient going to stop with one slice? That is a very, very important question. Nobody stops with one slice. So remember, the riper the mango, the more the trouble. Now, another important thing is in bananas, there are so many patients who will come and say, Madam, I have constipation. Unless I eat banana, I cannot be relieved of constipation. Usually, we do not prescribe bananas to patients, but if they still insist and their blood sugars are super controlled, you can think of Yelaki banana, but that's also another problem. Nobody stops with one Yelaki banana. If you look at the Yelaki banana, the GL is 10.7. So, I wouldn't say that's the best choice, but you have so many other fruits. Those who are constipated, better to avoid apple because pectins in apple constipate. So I usually suggest the patients step up physical activity, step up insoluble fiber, cut down the soluble fiber, and you will see that the constipation is improved rather than relying on a banana. Another important thing is GI and GL of tender coconut water is quoted in so many textbooks that it has a low GI and low GL. Believe me, we've only seen postprandial peaks. It's a super source of potassium and probably some amount of sodium and fluids, but not a very good source with reference to glycemic control. And dates, a lot of patients take dates. In fact, I had the opportunity to have a paper published with Professor Anup Mishra et al., wherein we found that dates have a GI from as low as 8.5 to as high as 24. And the ones which are available, which are the lowest GL, that is 8.5, is the Majdool dates. They are the dates which are available only in Saudi Arabia, not in India. We don't have those dates which are glycemic friendly dates. Otherwise, the ones which are available are as high as 74.6 or 103 GI. So millets. I think this is a very, very vast topic, and I have addressed this topic several times, but still for all benefit that they are prebiotics, they are rich in copper, magnesium, protein, calcium, phosphorus. But GI, you will see that there is a variation in GI. It's the barnyard millet and the foxtail millets which are most glycemic friendly in comparison to other millets. But when millets are combined with pulses, whole grams, or with the fenugreek, that is a Vendium when we consume, or when they are boiled against the rice, or they are baked or toasted like the dosa or the chapati, or they are fermented like the idli, dosa or the dokla, you will find that millets are glycemic friendly. But in spite of them being glycemic friendly, I said two important millets, that's the barnyard millet and the foxtail millet. The second important thing is bajra is one big no-no. It needs to be malted at least for 48 hours, otherwise it's goitrogenic. And all millets between 306 to 348 calories per 100 grams, 8 grams of protein, 8 to 12 grams of fiber. So this is the nutritional composition. You still have to have portion control. You cannot say that millets are, fairly good. They are micronutrient dense. They are very healthy. They are high in fiber. They are prebiotic in nature. They have the magnesium, but still portion control holds good. So when it comes to millets, I made a mention. Another important thing with millets is if you buy the millet flour in the market, it could be a polished millet flour. It's not going to do good to you in any way. So buy the millets as a whole millet, never like a flour. And this was a wonderful paper by Dr. Mohan's Diabetes Center, where they found 40 stores. Among the 40 stores, 90% of the stores offered polished millets. So be very careful with that. Another important thing with millets is there was one classic systemic review with 1,000 subjects, 80 studies, 11 countries, and 11 different types of millets were studied. What did they find? They found there was a dip in the blood glucose. There was an improvement from the pre-diabetic to the non-diabetic status, from the diabetic to the pre-diabetic status. So that is the power of millets. But in combination is the best. As I mentioned to you, they should be with legumes or with fenugreek. Another important point, when they found that when they cooked a millet or boiled a millet against a rice, the GI was much lower. Or when they, as I mentioned to you, when you prepare a dosa or a chapati, I usually tell my patients, when you want to use millets, the best way is ferment them or sprout them. As a weaning food, we use it as an amylase rich food, that is a sprouted ragi, not in the form of a porridge. Most of the patients take a porridge in the morning and then they will eat 3 idlis. So that's the worst thing they can ever do. So use it like an ade or a murumkira, you add it and make an ade. Or all millets you add with rice and urad dal in equal ratio, and you can do it the best way that way, because you are going to inactivate the goitrogenic property. Not only that, you are going to make the micronutrients bioavailable. So there are so many more papers with reference to cardiovascular health, and most of the papers are with foxtail millet. Another important thing with millets is it is gluten-free. So a lot of our type 1 children who have gluten sensitivity, it is one of the very good options to wheat. And as I mentioned to you, anti-nutritional factors are important. So they can be deactivated by roasting, sprouting, or fermenting. The best method is to prepare idlis or dosas, but portion control is the key. And each millet has a specific, I would say, flag attached to it. For example, if it's proso millet, it's magnesium. If it's barnyard millet or foxtail millets, they are used for their vitamin B3. If it's finger millet, iron, calcium, phosphorus, potassium. So the host of things are there, but remember with millets, those patients who are having potassium-sparing diuretics, who have a GI obstruction, who are having esophageal varices, or cirrhosis of liver and pancreatitis, you may not be able to prescribe millets to them. So variety, balance, moderation in quantity, quality, and time of the meal you choose is the key to good glycemic control. You are what you eat. I am grateful to TRACK 2024, the entire organizing and scientific committee of TRACK 2024 for this opportunity. Thank you so very much.
Thank you, Dr. Meenakshi, for covering such a vast topic. I know you were a little upset when we said 10 minutes, but you were able to do it. Thank you. So now we go on to the next topic, ultra-processed food and its effect. So usually when the father is not able to come, the son comes and takes over. Here it's other way around. The son is not able to come, so the father is going to deliver the lecture. Dr. Paneer Selvam.
Good afternoon. Thanks to chairs and good friends, Dr. Madhavan, my teacher, and Anand Moses, and GVK, and all delegates. So the ultra-processed food and its effect for the past 5 or 6 years, the ill effects of ultra-processed food keep on coming as articles. So I simply want to convey, if you cut vegetables like your cucumber, tomato, carrot, wash and cut and eat, that is unprocessed. If you cook and eat, processed. If you dry and deep fry, put salt and put it in the packet, the inner packet of the coating will store it for 3 months or 6 months. That is become ultra-processed food. So unprocessed, processed and ultra-processed. What are all the ill effects of ultra-processed food? So ultra-processed food definition, ultra-processed products are made from processed substances extracted or refined from whole food, that is oil, hydrogenated oil and fats, plus and starches, variants of sugar and cheap parts of remnant of animal food with little or no whole food. Products include burgers, frozen pasta, pizza, pasta dishes, nuggets, sticks, grips, biscuits, because now all children are started eating this only. Cereal bars, carbonated and other sugar-added drinks, and various snack products. Most are made, advertised and sold by large or transnational corporations and are very durable, palatable and ready to consume, which is an enormous commercial advantage over fresh and perishable whole or minimally processed food. They are typically energy dense, have a high glycemic load, has low in dietary fiber, micronutrients and phytochemicals, and are high in unhealthy type of dietary fiber, free sugars and sodium. So this is the classical definition or classical information on ultra-processed food. The rise in ultra-processed food and why they are really bad for our health. Many traditional food used in cooking today are processed in some way, such as grains, cheese, dried fish and fermented vegetables. Processing itself is not the problem. Only much more recently has a different type of food processing emerged, one that is more extensive and uses new chemical and physical technique. This is called ultra-processing, and resulting products are ultra-processed food. To make this food, cheap ingredients such as starches, vegetable oil, and sugars are combined with the cosmetic additives like colors, flavors, and emulsifiers. Think sugary drinks, confectionery, mass products, breads, snack foods, sweetened dairy products, and frozen desserts. Unfortunately, these foods are terrible for our health, and we are eating more often than they ever before, partially because of aggressive marketing. See, marketing is the two, visual media marketing, aggressive marketing, and lobbying by the big food. Ultra-processed food are harming our health. More ultra-processed food in diet associates with the higher risk of obesity, heart disease, stroke, type 2 diabetes, cancer, frailty, and depression and death also. These harms can be caused by foods poor in nutritional profile, as many are high in added sugar, salt, and trans fats. Also, if you tend to eat more ultra-processed food, it means you probably eat fewer fresh food and less processed food. So again, same information again. The third line, ultra-processed food sales are booming nearly everywhere in the world. Sales are highest in rich countries like Australia, the United States, and Canada. They are rising rapidly in middle-income countries like China, South Africa, Brazil, and highly populated places, including India. Growing evidence from large prospective cohorts show that ultra-processed food is associated with adverse health outcomes such as overweight, obesity, cardiovascular disease, and type 2 diabetes. Systematic review showed that high ultra-processed food consumption was associated with increased risk of all-cause mortality, cardiovascular disease, metabolic syndrome, depression, and postmenopausal breast cancer also. The shift from unprocessed and minimally processed food to ultra-processed food and their subsequent increase in contribution to global dietary pattern in recent years have been attributed to the key drivers of including behavioral mechanism, food environment, and commercial influences on the food choices. The intensive industrial processing of food may produce potentially harmful substances that have been linked to higher risk of chronic inflammatory diseases, including acrylamide, advanced glycation product, furans, heterocyclic amines, industrial trans fatty acid, and polycyclic aromatic hydrocarbons. These are all very harmful, inflammatory. Ultra-processed food can contain contaminants with the health implication that migrate from packaging material such as bisphenols, microplastics, mineral oils, and phthalates also. Even our disposable plastic bottles are having some microplastics. So how to eat healthy in an unhealthy world? This information is 2017. How to eat healthy in unhealthy world. So why junk food is slow poison, how it affects our health. Disadvantages of junk food, of course, increased obesity, heart disease, diabetes, and other, etc. Fast food contains high carbohydrate, but fiber not at all. So these are all the few items. We have failed to give diet advice, says former FDA chief. Better answers to basic nutrition question needed. See, he was FDA chairman 2018. He himself is accepting we have failed to give diet advice. So the information, what happened in 80s that changed the world? Overproduction of food, much greater extent than the food had to be sold. The shareholders' value movement on Wall Street meant that food corporation, like all other corporations, not only had to make profit, but they had to grow their profit, and we deregulated a lot of controls around marketing. Kessler had different intake. We took fat, sugar, and salt. We put it in every corner. We made it available 24/7. We made it acceptable to eat anytime, walk or drive into any places and eat. It is the way I have good time, I can unwind, I can feel good. In our country also, in Madras also, even by 12 o'clock or 1 o'clock in the midnight, you can have biryani. So to that level, our country also getting spoiled. Undernutrition was the cause for many diseases during Esther years. That is your kwashiorkor, marasmus, etc., rickets, etc. Now, unwanted nutrition is the cause for many diseases. So we should know what do you mean by undernutrition and unwanted nutrition. Again, another article, ultra-processed diet or excess in calorie intake and weight gain and inpatient randomized controlled trial of ad libitum food intake, ultra-processed diet, unprocessed diet. Ultra-processed diet, the quantum of intake is more when compared to unprocessed diet. Similarly, body weight for ultra-processed diet is higher when compared to unprocessed diet. This is another article in 2014. Consumption of soft drinks has increased 5-fold since 1950. Meta-analysis suggests that consumption of sugar-sweetened beverages is related to the risk of diabetes, metabolic syndrome, and cardiovascular disease. Drinking 16 pounds, 500 ml of soft drinks per day for 6 months induced features of metabolic syndrome and fatty liver. Some of our colleagues are taking, instead of water, even our own medical colleagues are consuming everyday soft drinks. Because soft drink cost is equal to your mineral water, they drink soft drinks. Randomized controlled trial in children and adults lasting for 6 months to 2 years has shown that lowering the intake of soft drink reduced the weight gain. Consumption of calorie-sweetened beverages has continued to increase and plays a role in epidemic of obesity, metabolic syndrome, and fatty liver disease. Reducing intake of soft drink is associated with less weight gain. Our fruit juices are just unhealthy as sugar-sweetened beverages. Fruit juices are still widely perceived as healthier option for soft drinks or sugar-sweetened beverages. However, they often contain as much sugar and as many calories as SSB. Although the sugar is 100% fruit juice, is naturally occurring rather than added. Once metabolized, the biological response is essentially the same. So some of them are under the impression fructose is good, but fructose is getting converted to glucose only. So consequence of the increased fructose and energy intake, ultimately your NAFLD, obesity, diabetes, etc. These are all the various morbidity due to ultra-processed food. So as association of ultra-processed food consumption with all-cause mortality and specific mortality population-based, again we found that ultra-processed food intake was associated with higher neurodegenerative mortality. Increasing evidence suggests that ultra-processed food is linked to higher risk of central nervous system demyelination, lower cognitive function, and dementia. Studies have shown that diet rich in ultra-processed food may drive neuroinflammation and impairment of the blood-brain barrier, leading to neurodegeneration. Of note, among ultra-processed food subgroup, dairy-based desserts showed that strongest association with neurodegenerative mortality. So again, ultra-processed food consumption and cardiometabolic risk in children. Of course, BMI, waist circumference, fat mass index, fasting plasma glucose, lower HDL, these are all the adverse effects. Of course, substituting your 100 gram of ultra-processed food with 100 gram of unprocessed food, BMI is low, fat mass also low, fasting plasma glucose also low. So our obesity in the children also keep on increasing. This is 2010 information in the Hindu. So these are all the obese children we come across in our clinical practice also. Sugar causes disease. Excess sugar, dementia, diabetes, obesity, high triglyceride, hypertension, CV death, etc. Avoid refined carbohydrates. High carbohydrate diet increase sharply the blood sugar. So meat, seafood, and poultry ready-to-eat food had strongest association with mortality. Western diet, which invite all non-communicable diseases. So obesity increases once the refined carbohydrate keep on increases from 1960 to 1995, obesity also increases. In our country also, consumption of your jalebi or son papdi, they are all rich in fat, energy as well as carbohydrate. And soft drink consumption also in India is increasing from 2000 to 2015. So this particular patient at the time of introduction of your IT, 2002, fasting blood sugar 860, postprandial 1128. Another patient, again at the time of introduction of IT, 2002, cholesterol 680, triglycerides 6743. We do come across such reports even now because of IT booming. So again, Portugal brings down the obesity by taxing the sugary drinks, nutrient warning on unhealthy food, overconsumption of ultra-processed food and sugary drinks increases the risk of obesity and type 2 diabetes and heart disease. Britain will restrict promotion of unhealthy food from April 2022. Ultra-processed food are pushing aside all other food groups to dominate global diet and should be regulated with the tobacco-style warning and advertising bans in 2024 June. So dietary spectrum, what America eats, high energy-dense diet, whole food plant-based diet is good as our previous speakers, Dr. Meenakshi as well as Vasiji told, eat fiber, high fiber diet when compared to other diet. They are all healthy. So instead of filling the stomach with ultra-processed food, better to fill the stomach with a plant-based diet. Nutrition education in the curriculum. See, in all countries studied, nutrition education was insufficiently incorporated to the medical curriculum across all years of study. The lack of adequate nutrition education translated into reduced knowledge, skill, and confidence among students when implementing nutrition care. Dedicated curriculum initiative had modest positive effect. Medical students are not educated to have knowledge and skill required to provide high-quality nutrition care. Further initiatives are needed to improve the teaching of nutrition in the medical curriculum, because many of us are not at all talking about nutrition to the patient. We look at the number and write the medicine rather than talking to the diet. Diet plays the dominant role in the management of metabolic syndrome. So better to go for plant-based diet and unprocessed or processed diet. Thank you.
And we'll come to the last talk before going into the panel discussion. Mrs. Kalarani. Very interesting topic, something, some protein drinks and with fiber for diabetics. I think this is very interesting. I think we should be able to prescribe these things if we can convince us.
Good evening all, and I thank the organizers for giving me the opportunity to share this chair. And I'm Kalarani, I'm dietitian from Rajiv Gandhi Government General Hospital. And the topic given to me, it's just 10 minutes, so I'll just straight go to the topic, and it is fiber protein drink. See, the organizers were very intelligent, so they have clubbed 3 topics. So now I need to talk about protein, fiber, and water. Okay, so now let's first start with the protein. So various studies have shown that in diabetes, the loss of muscle mass and muscle strength is high when compared to non-diabetic individuals. So this phenomenon, we call it as diabetic sarcopenia, and the risk of sarcopenia is 1.5 to 2% high in diabetic individuals when compared to non-diabetic individuals. And so sarcopenia is the new risk factor, a new complication of type 2 diabetes. So this not only leads to a poor quality of life, but it also leads to physical inactivity, and finally it can also lead to death. So now let us see what are the key factors which causes this low muscle mass. So the first one is insulin resistance. We all know that insulin is critical. It plays a critical role in the protein synthesis and also the glucose uptake by the muscle cells. Now insulin resistance affects these 2 processes, and hence it leads to reduced muscle synthesis and increased muscle loss. Then the next one is chronic inflammation. Uncontrolled diabetes leads to chronic low-grade inflammation, and this releases cytokines, inflammatory cytokines TNF alpha and IL-6, and this leads to muscle wastage. Then the next one is poor glycemic control. Of course, it leads to hyperglycemia, and hypoglycemia affects the protein synthesis again, and it leads to muscle wastage. Then mitochondrial dysfunction. So the muscle cells need energy, and the energy is supplied by mitochondria, and diabetes affects the functioning of the mitochondria. Again, this leads to low muscle mass. Then decreased physical activity, it causes muscle atrophy, and that leads to muscle weakness and muscle strength. Then impaired protein metabolism is seen in diabetes, and then insulin growth factor 1 is lower in diabetes, and hence this leads to muscle weakness. So these are the causes which causes muscle loss and muscle weakness, and how it affects the clinical consequences of the low muscle mass. So it leads to reduced mortality. So, reduced mobility, and this will cause free fall and fractures, and then metabolic decline is seen, and that is due to the insulin resistance and poor glucose control, and then increased fatigue that leads to reduced physical activity. Now the solution for this. That is the dietary protein. So when we say dietary protein, the daily requirement is 1 to 1.5 grams per kg body weight, and it varies from individual to individual. So based on the patient's weight, we decide whether it is 1 grams or 1.5 grams. And what we need to note here most is the protein has to be of a good quality protein. So what do we mean by a good quality protein? So we have two sources of protein. One is plant-based and the other one is animal-based. So when you go for animal-based food, look for a low-fat protein substitute. So we go for lean protein, then fish and egg white can be had as a protein source. Now when you come to the plant source, be very particular that, of course, the protein-rich food, immediately what comes to our mind is pulses and legumes. So when you take pulses and legumes and even nuts, you make sure that you have it along with the cereal. So the cereal pulse combination is the best quality protein which you can get in a plant-based food. So our ancestors have been well aware of it, and most of our Indian food will have the cereal pulse combination. If you see idli, you have the rice and dal combination, pongal, again rice and dal. Then when you have chapati, they have it with chapati chana or chapati dal. So whether it is north or south, our food is balanced. So better stick on to the Mediterranean diet or our own ancestral diet if you want to have a high quality protein. Then the next one is fiber. So now let us, we all know like a high fiber diet helps in diabetes. So what are the benefits of fiber? So the first one is it improves the glycemic control. So how is it done? The soluble fiber, it forms into a gel. And then it decreases the digestion and absorption of the food, and that helps in lowering the sudden glycemic peak. And then the next one is enhanced insulin insensitivity. In type 2 diabetes, insulin resistance is very common. But when you have a high fiber diet, there is an increase in insulin sensitivity which can help in maintaining the blood sugar. Then the third one is lower risk of heart diseases. So we all know that fiber helps in lowering the cholesterol, especially the low density lipoprotein, and this will benefit the diabetic patients. And then the third one is it helps in managing the weight. A high fiber diet, we all know, like it increases like the non-soluble fiber, it increases the bulkiness of the food which goes in, and this will help in the lower absorption and hence helps in the weight reduction. And of course, when high increased weight, we all know, will increase the risk of insulin resistance and poor glycemic control. Then the last one is gut health. The non-soluble fiber, though it doesn't directly involve with the glucose maintenance, it improves the gut bacteria, and thereby it helps in maintaining the metabolism. Now, when it comes to fiber-rich diet, we all know like there are two types of fiber, that is soluble fiber and insoluble fiber. And as I told before, the soluble fiber, it forms a gel by mixing with water, and this helps in like this delays the digestion and absorption. And some of the food sources of soluble fiber are like you will see, it is barley, nuts, seeds, beans, then lentils, fruits. So all these things are soluble fiber. Then when you, on the other side, if you see the insoluble fiber, the whole cereals, the whole wheat, whole grain, and then vegetables, all nuts and oil seeds like make the insoluble fiber. So now next one is fluids. Okay, so it's 2 minutes more. Okay, so fluids, it prevents dehydration. And moreover, like when you take a high fiber diet, the fiber takes up a lot of fluids and it can lead to constipation. So in those cases, you have to have more fluids in your diet. Then the next one is like when you have more fluids, it helps in the excretion of excess glucose through kidneys. So if you lower your water intake, then it affects your kidneys, nerves and cardiovascular systems. Then the third one is it helps in maintaining the blood sugar, because even slight reduction in your or a slight dehydration will lead to high blood sugar. So, so combining all these things like protein, fiber and fluid, so I have given few simple, because even fiber like artificial fiber can be given, but still always go for homemade foods. So the first one, it's not very complex, pureed soup. You just put little bit of tur dal and whatever vegetable available in the cooker, pour some water, and once it is cooked, you just puree it and have it with pepper and salt. The next one is milkshakes. Any fruits, like you just put it in with 50 grams of milk, and if you have cardiovascular risk, then have skimmed milk. And then again, you just put it, whip it, and then you can have your milkshakes. You can add few nuts also to your milkshakes. Then thick soups, like you can just put everything like same like the pureed soup, but you can have with the vegetable pieces, so it can be like it can give variety to your food. And then the last one is stew, and whey water is very healthy, as you know, like it is rich in protein. So you can just steam boil the vegetables and mix it with whey water and put some pepper and salt. And that also, these foods can be had as mid-morning snacks, or evening also you can have it. So when it comes to meals, always see to it that's a cereal pulse combination for all 3 meals. Okay? And thanks for giving this opportunity. I think I finished it on time. Thank you.
Thank you. Thank you, Dr. Vijay. Next, we honor Dr. Shanmugavelu, who was the next secretary, who was the 3rd secretary, isn't it? 3rd secretary. Dr. Asirvadam was the 1st secretary, Dr. Vijay 2nd, Shanmugam 3rd. The topic is open for discussion. Who wants to have the first question? Yes, Dr. Raghunandan, former professor of medicine from Madras Medical College.
Sir, regarding the topics what have been discussed, one of the key thing was milk. I think today the trending is so many types of milk, like oat milk. Even within the Arvin milk, there are so many brands are there. So, what is the current
The 4
consensus?
speakers can come here.
Something like, if they can throw some light on the milk, and
Neil,
also some proteins are also enhanced. The protein
Yes.
content of milks also has been enhanced, and it's being advertised in papers.
Yes.
So, what is the take on that?
Who wants to take the question on milk?
For those patients who are lactose intolerant, they can choose on oat milk or soy milk. But milk per se, it's a source of whey protein and casein. And there is some amount, if you are going to choose on milk for PWDs, for persons with diabetes, I would suggest low-fat milk because of the whey protein present in it. And there is enough and more evidence to tell us that it is insulinotropic. It provides satiety. It helps to improve immunity. Also, the whey protein also helps to reduce oxidative stress, reduces cell autophagy, and helps to improve sarcopenia. But remember, whenever we are choosing milk as a source of protein, it's a good quality protein, but low-fat milk is the key with reference to, whichever evidence you take up. The reason being, All of us go to a restaurant or party, wedding, birthday. So we are consuming saturated fat in some form or the other. And you take any guideline, RSSDI, ICMR, ADA, AHA, it all says between 7 to 10% saturated fat. So we are meeting our saturated fat content from other food sources. So we don't need to rely on milk for the saturated fat. So prefer to take skimmed milk. And protein, the EAR, that is the estimated average requirement by ICMR, is only 0.8 grams for you and me. So that is the requirement of protein. Depending, somebody's tuberculosis, post-operative, cirrhosis of liver, or post-dialysis, or transplantation, you may require a high protein, or even cancer from as high as 1.2 to 2 grams. We have also AKI, critically ill. Those patients also may require 1.2, 1.5, 1.7, 2 grams of protein. But whenever protein is prescribed, remember the fluid has to be stepped up if there is fluid allowance in that particular patient, and sodium has to come down. Otherwise, we are definitely going to overload the kidneys. So that's my take on protein.
So I have two queries.
Thank you, Meenakshi.
What is the real advantage of soaking the almond overnight?
Sir,
And the next one, I think the recent study says the cashew nut contains only plant protein, not animal. Is it true?
It is not animal protein. It is plant-based
It is only
protein.
plant.
But it is a source of saturated fat apart from the MUFA, PUFA. So it is a combination of all the three. You cannot say that it is completely healthy fat. It is a combination of all three fatty acids. It's got as high as 28 grams of saturated fat. Remember that it has got a source of MUFA also. And I have also showed to you the paper which was published by Dr. Mohan et al., wherein they have shown 30 grams coming from cashew nuts for a period of 3 months. They found that the HDL cholesterol did improve and the blood pressure did improve. But remember, calories come, so only 5 cashews will give you 85 calories. But they should not be roasted and fried. They have to be taken in the natural form, and it's a plant-based source. Second question was, why should we soak almonds overnight? The reason being, it has got anti-nutritional factors like phytates, which need to be inactivated. Phytates, tannins are present, which needs to be inactivated. So when you soak it overnight, it gets inactivated. Second is, the bioavailability of zinc and the digestibility of protein improves when you soak it overnight. And morning, you need to remove the layer of the skin. Only then it's useful for you. And as I mentioned, 12 almonds or 14 grams of almonds is equal to 85 calories. So usually I tell my patients, if they do not have nephropathy, to take 1 handful of almonds about 5 to 10 minutes prior to their breakfast or lunch or dinner, and remove 1 idli or 1 dosa or 1 chapati, and you will see wonders with reference to postprandial control, but provided the patient is not having a protein restriction in their diet.
But nowadays it comes with the roasted.
Do you have another question?
Roasted are AGEs,
Roasted
sir. Advanced glycated end products, they are not going to do good
What
to
is
us.
your question?
Sir, actually my thing is from my thing, sir. Experience is that my father was in milk industries.
Meenakshi, you can come and sit.
Regarding the milk, sir, my father was in milk industry, so we have seen everything, sir. Like whenever you say skimmed milk, ideally, if we are taking skimmed milk, please avoid the packet milk, sir. My father always used to say, because in packet milk, actually skim milk we will say, but the adulteration which is done, mainly in case of summer season, they use the powder and then they make a milk. Whatever major companies you see, sir. So that is the milk which we should not, better to avoid.
No, we usually tell our patients, whatever milk you're buying, buy the least fat percentage, 3% or 2%, skimmed milk, not powder, the liquid milk. If not, if you're buying 5% or 7%, boil it, keep it overnight in the fridge, remove the layer of cream and then use it. Usually if you go and buy directly skim milk, it's quite expensive. So economical way of telling our patients is whatever milk variety you're buying, as much as possible, buy the lowest fat. In case you're not able to do it, buy the milk, boil it, cool it, keep it overnight in the fridge and remove the layer of cream. Anyway, thank you so much for the insight, sir.
And now it's believed that diabetes and sarcopenia are bidirectional. Diabetes can cause sarcopenia, and sarcopenia itself can be one of the pathological mechanisms for diabetes. In fact, sarcopenia is now even considered to be a complication of diabetes now. So those youngsters who are going in for intermittent fasting, are they at increased risk of sarcopenia and diabetes?
Of course, sir. In one of my presentation, if you see one of the slides clearly says that the basic side effect of having an intermittent fasting is loss of proteins, loss of minerals and vitamins. So what happens is that many people want to follow intermittent fasting, but they don't know what is intermittent fasting, how it needs to be followed. So what happens is like intermittent fasting is not only a diet caloric restriction, but also it has to contain all the essential nutrition which is required. So even if you advise an intermittent fasting, we tell people, please go to the dietitian, make sure what calorie restriction and what is exactly required per a day, so that you don't have this problem. The second thing is what I understood in my basic practices. There are people, despite taking adequate protein, will have sarcopenia because of the disease process or the pathogenesis itself. So those patients might require additional nutrition. And in my opinion, most of our diabetic patients, at least 70% of the diabetic patients are sarcopenic. We do think that they have taken adequate protein, but our diet is basically very rich in carbohydrates, and they don't take the sufficient quality or the quantity of protein which is required on day to day. So I think intermittent fasting is a good one, provided that you have the right composition and do not be deficient on those diets.
Thank you.
Dr. Ashwin, one more question to you. I said you are open to a Pandora box. See, of the social media's agog about intermittent fasting, and problem is that people and even healthcare providers are confused between a non-diabetic person and a diabetic person. So those things can be advocated in a non-diabetic person, but in a diabetic person, you need to be very careful. See, the old saying always we used to say is that no fasting, no feasting. And you also said that, that one day you can binge eat and all. Those things I think in a diabetic may be totally avoided. That's a better thing to do that. And then, always used to say that, in fact, Sam G.P. Moses used to say that, cut the calories, cut the food. And that itself is more than sufficient for whatever benefits that we can get. What is your comment about it? Because I'm very happy that you came out with that negative study that has said that intermittent fasting has increased the mortality rate. So I'm very happy about that you brought it.
In the same line, a small clarification on that 8-hour fasting and increased mortality. I just couldn't understand that.
So the basic, that was a negative study which you published, and it gained a lot of momentum among public because it was from the AHA. So what it basically said is that they examined all the 20,000 people who had an intermittent fasting somewhere or the other in their lifetime. So they said 8 hours and 10 hours between that they ate and then it started fasting. And even in the ADA, it clearly says one particular thing, is that any kind of diet or time restricted diet or any kind of paleo, keto, it doesn't matter. All these diets are doing is a restriction of your calories. And only a healthy diet is supposed to be found to be effective. They say that in all these diets, for the first 12 weeks, you can see a weight reduction of 5 to 10%, but it might not sustain.
I have a question.
Yes, sir.
Ashwin, I missed your talk, but there is a concept of pre-sarcopenia, which has been shown in Indians. So what is the difference between pre-sarcopenia and sarcopenia? That's the first thing. The muscle strength should be tested. In pre-sarcopenia, the muscle strength is preserved. In sarcopenia, the muscle strength is lost. That's the main difference. Dr. V. Mohan, my brother, has studied pre-sarcopenia, has reported pre-sarcopenia, not sarcopenia. So the hand dynamometer is used by Anup Mishra to measure the sarcopenia. And we are asked him to talk on sarcopenia. But pre-sarcopenia is a definite entity which you should not miss. So muscle strength is retained, maintained in pre-sarcopenia. In sarcopenia, it's lost. So that's the difference between pre-sarcopenia and sarcopenia. And you use the hand dynamometer. There's a particular brand which Anup Mishra uses, and only Anup Mishra has published from India. Nobody else has published from India on sarcopenia. Anup Mishra has given a lot of examples. You can't get up from the seat, can't get up from the chair. You have sarcopenia and so on, clinically. But I had a discussion with him. he says the hand dynamometer, we bought it, and we're doing a study on sarcopenia and pre-sarcopenia in diabetes. So I missed your talk, sorry.
Thank you, sir.
Any questions from the audience?
See, now I have presented 4 studies which said that 3 are in favor of good outcomes, 1 is in favor of against outcomes. So what even that negative study clearly says is that out of this 20,000 people, from the database they have identified this. But they said that they don't know why it caused it. They are not sure on what is their background and what background it is, how did it happen. So they said that they need further studies. So until then, we can only know that intermittent fasting is only for particular people. And most of this is from the Western data. We don't know what is our data, or we don't know what is the South Asian data. So we need to do more work on this. But when I browsed to read about more of intermittent fasting, I saw very, very few negative studies and a lot of positive studies which has been beneficial, especially in Indian population. And whenever you Google intermittent fasting, and you can see that this has not been followed by us only now. It has been followed from the ancient times, and all the religion has one or the other where you have this intermittent fasting now and then. In Muslims, in Ramadan, in other things, for Christians it is Lent period, and for ours it's Navaratri, or maybe on Tuesdays, on Thursdays, and Karwa Chauth and whatnot. I think that this has not been invented now, it has been invented from the ancient times.
Upavasam.
Excuse me? I just
question.
have one thing to say. See, even the ancient thing, it was not a regular diet pattern. See, yearly once or monthly once, that was the duration. But nowadays, people take it up as their regular pattern. I think that is where we differ. And the reduced research paper, maybe because only recently people are going in for the intermittent fasting. So that could be the reason why the researches are low. And I personally feel as a regular pattern, intermittent fasting is not good. So occasionally, monthly once or yearly once. So that is how it has been in the ancient practice. So that will definitely benefit. It acts as a cleanser, but not on a regular basis.
There's a question on...
Right.
Yes.
Protein drinks are sold. Ensure diabetic protein. What's your comment?
Sir, as I told in the last slide, see, always go in for homemade food. Don't go for any packed food.
The next question is on oil.
And,
oil for... the question is directed to Vasugi. And something on coconut oil, You had put up, it contains a SFA of around 80%.
Yes, yes.
Is it a healthy oil? Because it is the most extensively used oil in Kerala, and people from Kerala are so healthy with a glowing skin, No. And compared to other people. So, Vijay, you have anything on data from Kerala on use of coconut oil?
No, the reason is cardiovascular disease is supposed to be lower in spite of smoking. They do a lot of smoking, and alcohol is very high.
But
in spite of that, cardiovascular disease is...
But the SFA I saw was 80% in...
Sir, actually, as per papers, coconut oil and palm oil have high saturated fat content, sir.
Yes.
So they can be used... actually, one good thing about the saturated fat is, one shocking thing which I found is the vegetable oils, oils which contain PUFA, when you're using it for deep frying, they might get transferred to trans fat. So that is one advantage of coconut oil and palm oil, that even when you're going to heat it, they will remain a saturated fat only. Trans fat production is less, number one. Number two, generally we are using it for tempering, sir. அதாவது தாளிக்கிறதுக்கு அதுக்கெல்லாம் யூஸ் பண்ணிக்கலாம்.
No, but regular cooking itself in Kerala.
Yes, and the banana chips and all they are using, sir. But as per saturated fat, Western data padi, it should be less than 7%. Western data, if we go with the AHA, saturated fat consumption should be less than 7%.
So you don't recommend?
So actually the recommendation is between the recommendation is between PUFA and MUFA, sir. Adudha vandu blending of oils la, we are using it with PUFA and MUFA only.
Right.
So
Anyway,
regarding intermittent fasting, I have one point to add, sir. If you
one
please allow.
final point, because Shanmugam is waiting with the mementos. Indeed. Yes, your final point is taken. Yes.
So for intermittent fasting, regarding intermittent fasting.
Too many things on intermittent fasting. You can give your final.
No, sir, regarding the two things about the sarcopenia, we are not talking about the biochemistry behind intermittent fasting, sir. This I have been telling it, two things, why there is sarcopenia and why we have an increased risk of CVD mortality with intermittent fasting is, once the body has to bat on some fuel, suppose we are not taking glucose, body will go for free fatty acids and ketone body production. And for the production of neoglucogenesis and glycogenolysis, we need the counter hormone excess. This is how the body is going to work. Sarcopenia, because neoglucogenesis after the fat. See, when the body is going in for fasting, first to break down is a lipid, second to break down is a protein. So muscle breakdown will start happening. Alanine, so first neoglucogenic amino acid is alanine, and alanine is coming only from the muscle. So the moment the lipids have started, we are exhausting the lipids, the weight is coming down. The body is going to bat for skeletal muscle breakdown. So this is one reason sarcopenia is major adverse effect of intermittent fasting. As madam rightly pointed out, it should be intermittent only. Intermittent fasting should not be continuous. It should be intermittent as per biochemistry. Number two, how the CVD mortality, what explanation I want to give is, so when the body is batting on free fatty acids, there will be an increase in catecholamine surge. So catecholamines has to increase, growth hormone has to increase for the body to go for a lipolysis.
I think
and actually
the discussion also should be intermittent.
Okay, sir, thank you.
Okay.
We can stop here and go for the memento. So I think all 6 of you have done, 5 of you have done a wonderful job. 6 of you, is it? I request you to give a memento to Dr. Ashwin Karpal. Second to Dr. Vasugi. Second to Dr. Vasugi. Third to Dr. M. Raja. Thank you, Dr. Bharat. Thank you, sir. Now I call Dr. K. Shanmugam. I think a senior most member of the organization, senior most member of API. You give the memento to Meenakshi Bajaj. Dr. Raghunandan, please come to the stage. Thank you. I think we come to the end. We have come to the valedictory function now.